morning, everyone. Thanks so much for joining us at our breakfast webinar this morning. If you want to go ahead and introduce yourself in the chat so we know who's with us in the Zoom room today, please open up that chat box, make sure it's clicked to go to everyone. And if you want to share your name and where you're zooming in from today, it'd be great to see who we've got this morning. Good morning, everyone. Thanks so much for joining us at the Hudson River Watershed Alliance's monthly breakfast webinar. My name is Emily Vale. I'm the Executive Director of the Hudson River Watershed Alliance. And if you're just joining us, please open up the chat box and write in, make sure it's clicked to go to everyone, your name, your affiliation, where you're zooming in from today, so we have a sense of who's with us in the Zoom room. The Hudson River Watershed Alliance is presenting a series of programs this fall focused specifically on drinking water. We've gotten a lot of questions from our communities about what we all can do to protect drinking water, questions around some of the latest science and strategies. And so we've put together a program that is in a variety of different forms, bringing that information to you all. So last month, our breakfast webinar focused on building collaborations for source water protection with a focus on the drinking water source of Peekskill, New York. And we're leading up to our annual watershed conference, which has a focus on drinking water from source to tap. So our annual watershed conference kicks off next week with a webinar session on Wednesday, October 16th. We'll hear from representatives from the Department of Health and the Department of Environmental Conservation on state roles, and a case study from the City of Albany's Water Department on how water is treated at the source through the treatment plant process and how they communicate it out to the public. The annual watershed conference continues with an in-person session all day on Tuesday, October 22nd at the FDR Presidential Library in Hyde Park, and we'll dive even deeper into the latest science and strategies in thinking about drinking water, particularly from a watershed perspective. So if you haven't yet registered, Jen Cohen, our operations manager, is here on tech support. She's going to drop the link into the chat. Great. We have special ticket options for students and volunteers. And if you need additional financial support to attend the conference, please don't hesitate to get in touch. We've gotten donated tickets from several of our sponsors and supporters. So please reach out if you're interested in coming. Today, we're going to be focused on the health impacts of PFAS chemicals in drinking water. With some of the new regulations, more and more communities are finding PFAS pop up in their water supplies, and we're hearing a lot of questions about what that all means. Of course, the impacts have been particularly significant in Hoosick Falls and Newburgh, and we'll hear more about that from Dr. Bell. Dr. Bell is the Dean of the College of Integrated Health Sciences at the University of Albany, and I'll hand it over to her to present her slides. So just to get out ahead of some frequently asked questions, we are recording this session. Dr. Bell is going to be sharing her slides as a reference, so you'll be able to share those materials with anyone who wasn't able to join us this morning. We'll have time for questions at the end. So if you have any questions that come up, please use the Q&A box and we'll take those after the presentation. Thanks again for joining us, and I'll hand it over to Dr. Bell.
Thank you very much, Emily. It's a great pleasure to be with all of you this morning. The sun is shining here as we think about our friends in Florida. And so thank you so much for having me. And again, today I'll give an overview of where the literature currently stands with regards to PFAS and also a little bit of where we are with our efforts in Newburgh and Hoosick Falls with our studies and where we think we're heading with our information and work as we go. Just so that we are all on the same page as we have our discussion this morning, when we refer to PFAS, it's actually a family, the per and polyfluoroalkyl substances. is a family of about 12,000 different compounds. It depends a little bit on the source you read or the chemical structure you're looking for, but currently we're about 12,000 different chemicals within this family. They are used in manufacturing. They're handmade chemicals, synthetic chemicals that work very well in manufacturing because they repel oil and water. They're highly heat resistant. They reduce friction. They're used in a number of industrial processes and consumer products that we all find very useful. So our nonstick cookware, our waterproof clothing, firefighting foam, certainly takeout containers so food doesn't stick to the inside of those containers, and then carpets and textiles, so any stain or water resistance. And that's usually a good, if you're trying to figure out if the product you have or you're choosing to buy might contain PFAS. If it's non-stick or water resistant or stain resistant, that's usually a good sign that chances are that it has some level of PFAS in them. They're often referred to as forever chemicals, especially in the news media, because of their very long half-life. However, the newer PFAS in this family of chemicals are not as persistent, but that doesn't necessarily guarantee that they're safe. And I'll talk a little bit about that in a minute. When we think about PFAS in the environment, how they become apparent in our water systems, as well as in the soil and in the air, it's a very typical progression of what we see with many environmental chemicals, especially those that are more persistent. So we have exposures through manufacturing, so around the manufacturing plant, through the disposal of waste that often ends up in the rivers and in the aquifers over time, and then that can contaminate the drinking water systems through that mechanism. We also have household waste that, again, makes it into the wastewater stream and wastewater treatment plants. The biosolids that are created from the wastewater treatment plant processes can then be put onto fields. There's a lot of interest in that right now, as we're learning that process is now contaminating some of the soil in nearby states that have used that in agricultural land. In the past, there has been a process to try and incinerate, particularly the firefighting foam, and that could result in deposition of unincinerated PFAS, which of course is because they're heat resistant, is possible back into the soil and into the water. So again, something that we see on a regular basis with processes of deterioration and waste going into the water systems. People are then exposed through drinking the contaminated water, and for with the exception of the occupational workers, when we talk about communities that are exposed, even though there are many sources of exposure, right now the attention has been on exposures through the drinking water, since some communities have had quite high levels, as we have learned through Hoosick Falls and Newburgh. Those living near the chemical plants can have some exposures through the air emissions. I've already mentioned some exposures through food packaging and the use of non-stick cookware, especially once it gets scratched. You can then have that chemical exposures from those types of cookware. Contaminated food, fish and wildlife. Again, these substances, particularly the older ones that are persistent, is in the ecologic system and in the food system of our meat and dairy. And then occupational workers have some of our highest exposures. So firefighters that have used firefighting foam in training or in their companies. So not all firefighter companies will need to use foam, but those that do, and if they've had extensive training in it, their gear, and then therefore their bodies can have exposures. Also those who have worked in manufacturing plants. We also know that PFAS can cross the placenta. They also can be in the breast milk and expose unborn children and infants via those pathways. And I'll talk much more about that later this morning. I mentioned that the oldest perfluorinated chemicals are quite persistent. When we talk about persistence, we talk scientifically in the form of half-life. So how long it takes for half of the concentration of the PFAS, in this case, that's in your body, to be excreted. And for PFOS and PFOA, which are the most commonly studied perfluorinated chemicals, they were the first ones to be studied when we first started to investigate the health effects of these chemicals. That half-life is measured in years. It can take years for half of the concentration in your body to decrease. The good news is if you can stop or limit your exposure, you will naturally excrete the PFAS over time, but it can take quite a long time. Now, what often happens in environmental science, environmental health, when we identify a chemical that is a concern from a health perspective or from an environmental perspective, we often ban that chemical. And in fact, PFOS and PFOA have been slowly phased out of production over time, but they are then replaced by other chemicals. And usually those other chemicals that replace those that are being phased out have less persistence. And that is the case with PFAS. You'll hear the term Gen X or other terms of the newer PFAS, and they are less persistent. However, because they still have many of the same qualities of the more persistent chemicals, because that's why we use them in manufacturing, they have a similar chemical structure, and the concern is that the health effects of those chemicals are still a concern because we often re-expose ourselves more frequently. So they're not staying in our bodies for as long of a period of time. We excrete them very quickly in hours or days, but we have we tend to re-expose ourselves over time on a much more frequent basis because they're harder to measure and harder to regulate because they are less persistent. So that is something we're keeping an eye on in the scientific literature. PFAS are interesting with regards to that persistence. They bind to serum protein in our bodies and can also be reabsorbed through the kidney. They have what we call endocrine disruption properties, which means they interfere with our hormonal system. And anytime we have a chemical that interferes with our hormonal systems, we worry about a number of different types of health outcomes and endpoints that are related to the hormonal system, and this is quite a few. So it's a reproductive outcomes, impacts on child development, which is very much driven by our hormones, functions related to thyroid, and then certainly cancers that are related to the hormonal system are just a few, and we will talk more about that in depth in a moment. Some key milestones with perfluorinated chemicals. So the first lawsuits filed occurred in 1999 against DuPont related to the contamination in the communities in West Virginia and Ohio. And this led to a number of events leading off of that. One is again, the phasing out of some of these older PFOA and PFOS, and also the largest study to date in a community, the C8 study, which again is part of that lawsuit, enrolled residents in the communities exposed at the time primarily to PFOA. And a medical monitoring panel. And the studies that came out and the papers that came out of that research have really been the foundation for our understanding of the health effects related to PFOA and have led to additional studies. And the epidemiologists that worked on those studies are still very much active in the field and are consulted on a regular basis with regards to that work. And again, there has been additional work by EPA to understand, to work on regulation regarding the measurement of PFAS in drinking water, as well as to help us understand what the potential impact would be on health. The Environmental Working Group does track and has an interactive map on their website on the testing of water across the country. For these chemicals, and again, these numbers keep increasing as the testing ability of communities increases. Not all states had the rules in place to test PFAS until the new EPA regulations came out. And so this is changing on a fairly rapid pace. But as you can see, all states have at least one or two sites with higher contamination, and some of the highest contaminations are around, again, those manufacturing facilities or where we have airports or military bases where you're more likely to use that firefighting foam. With regards to the new EPA maximum contaminant levels, there was a multi-year process to EPA conducted to review the literature, to review the information available to them to set standards in the drinking water. The enforceable levels that have been passed are now set at 4 parts per trillion for PFOA and PFOS, 10 parts per trillion for PFHXS and PFNA, and again, in the drinking water. And then with the newer chemicals, Gen X chemicals in particular, also at 10 parts per trillion. Increasingly, we're understanding that these PFAS often occur in mixtures. Firefighting foam is actually a mixture of, largely composed of PFOS, also contains other PFAS in the families. And for this reason, as we start to understand what the health effects are and what the potential impact is of a mixture of PFAS, the EPA also put forth recommendations and regulations for a mixture of 4 of what they think at this point in time would be the most common PFAS to occur in mixtures, and also have measurement values in that. The first column that you see that's labeled MCLG are the goals. So the ultimate goal is to get to 0 in the drinking water for PFOA and PFOS. We don't yet have the technology, and water treatment facilities and agencies don't yet have the technology to get there, both for the testing, but also for the elimination of these chemicals from the drinking water. But this is a goal that has been set, and that allows the scientific community and the regulatory community to work together to keep working towards that goal. But it is something that will take time and money. And again, I've just put a sampling of some of the links and newspaper articles and websites for these new regulations that you'll have access to when I share the slides. Another tool that we use in examining health effects related to chemicals that are in the environment is the National Health and Nutrition Examination Survey. We'll refer to that in the scientific community as NHANES. This is a national survey that's used to help us understand what the level of exposures are in a community. So people are invited to come in, they have a blood draw, we measure a number of chemicals and other substances that we're interested in these study participant volunteers. And that gives us a sense of what might be happening nationally with these various exposures. So PFAS, especially PFOA and PFOS, have been measured since 1999 in this survey. And overall, the amount and concentrations of PFAS measured in blood in a random survey of study participants is going down because those have been phased out, but others are increasing because they have come on the market after the phasing out of PFOA and PFOS. And just to understand the context, when we talk about units and water exposures, you will often hear the phrase parts per billion, which is a microgram per liter, and that's about 1 drop in a swimming pool, whereas the new regulations of parts per trillion would be about 1 drop in 20 swimming pools. So it's a very small amount that we are asking to be monitored and to be measured. And again, the scientific technology to do that is constantly improving. And we can measure in parts per trillion for several of these PFAS, but the newer PFAS are a little harder to track in that way. We mentioned Hoosick Falls and Newburgh. When the contamination of the Hoosick Falls water system was first detected, the New York State Department of Health conducted a biomonitoring opportunity for residents in Hoosick Falls and then replicated that same process in Newburgh. And this was in 2016 that they did their initial testing. And you can see, I have to move my video here. In terms of the participants from the village where the contamination was for the village drinking water and those not on the village, the geometric mean of PFOA and micrograms per liter was quite a bit higher than what we see at the national level, and again was highest among those living in the village and therefore potentially having the most exposure because of the contaminated drinking water source for the village. And then Newburgh, which is on the bottom screen here, was also tested. They have a different mixture of PFAS in the drinking water, and again showing levels here for PFOS as well as PFH excess, were the two higher components in the study, the biomonitoring that was conducted in residents back in 2016 and late 2017. Both communities, Hoosick Falls had a second round that I'll show you in a moment, and Newburgh is wrapping up a second round of testing to look at the decreases over time in the community. At the same time, the biomonitoring project was conducted. A brief health survey was also conducted, and I actually have a doctoral student looking at some of those health survey results, and we hope to present those results to both communities later this year. We're just finalizing those analyses now, and so we're looking forward to presenting that information back to the communities. And this is, again, just looking at the city of Newburgh and comparing the N. Haynes data to show you that for the city of Newburgh residents, and it's also similar patterns that we saw for Hoosick Falls, that the levels in the population in both Hoosick Falls and Newburgh exceeded what we were seeing at the population level with the N. Haynes. So these are two communities that are particularly exposed, and it's a pattern we've seen nationally where we know the community has been exposed. Their levels are quite a bit higher than what is seen in the national sample. I mentioned that Hoosick Falls, before the pandemic, had time to complete their round 2 of testing. And so this allowed us to get a better estimate of what the half-life was for PFOA. And this is, again, an effort that was conducted by the New York State Department of Health and my colleagues, and they have this information on their website. And I believe the DOH representatives will also be presenting at the conference that's coming up. But again, the good news here is they are seeing a decrease over time in Hoosick Falls, but the levels are still higher than what we would see at the national level. Another example that I conducted in a study of 6,000 children. So back in 2007, I started in partnership with the New York State Department of Health, as well as the National Institute of Child Health and Human Development, which is one of the NIH organizations. We enrolled 6,000 children born in upstate New York between 2008 and 2010. This study was actually designed to look at a number of factors related to child development in New York, but it allowed us to look at environmental exposures in addition to some of the other markers that we were looking at. And what was unique about this study is that we asked the mothers for consent to sample the newborn dried blood spots that are collected at birth for PFOS and PFOA. We were the first state and the first study to do this, and this is through a method that was developed by scientists at the Wadsworth Laboratory, which is the public health laboratory for New York State Department of Health. The newborn dried blood spots, for those who might not know, are collected with a heel prick. It's 5 drops of blood, as you see here on the card. And that is collected from newborn infants to test for metabolic and genetic conditions that need to be diagnosed very quickly after birth so that the infant can receive appropriate treatment. Otherwise, lifelong adverse health effects will occur. And these cards are stored for a period of time, and with consent, and only with consent from the parents, we were able to pull these cards and take a whole punch sample from them to measure PFOA and PFOS. And the big message here is that while the amounts are small, in 99% of the samples of the just over 3,000 children for whom we had consent, we had measurable amounts of PFOA and PFOS. And so again, demonstrating that these chemicals can cross the placenta. These are all in infants less than 36 hours old. And with a measurable amount. And we have looked at these chemicals in comparison to other things that we measured in those newborn blood spots, most notably markers of the immune system. So immunoglobulin levels, as well as DNA methylation. So some slight changes in epigenetics that tell us there's been an environmental exposure. As well as when we are now looking at cytokine profiles, another marker of the immune function, as well as wheeze and asthma and some other aspects related to child development. And we do see small shifts. It's not enough to say this is an actual cause of disease at these low doses and low concentrations for the infants and children, but it does suggest that they have the capacity to make small shifts in the biological functioning of certainly the immune system, and that could lead over time to other outcomes. And it's something that we need to be aware of in the literature, and other scientists in other studies are also looking at this. I mentioned the C8 study earlier in terms of what they found in their cross-sectional study of almost 70,000 study participants, which is very large for an environmental study. It was a very well done study. They identified a number of outcomes that were concerning based on the PFOA concentrations, and they included high cholesterol, ulcerative colitis, thyroid disease, testicular and kidney cancer, and then pregnancy-induced hypertension. Since the C8 studies were first released back in the early 2000s, additional studies have also observed, again, this continued concern around endocrine disruption and the impact on the immune system, lower antibody production in children and adults. This is notable, and what this means is when a child with higher concentrations of PFAS in their blood are given vaccines, the ability for that vaccine to launch an antibody reaction to increase immunity from certain infectious disease might not be as strong. It doesn't mean the vaccine doesn't work. It might not be as effective as it is in children with lower doses of PFAS. And that information has been replicated in several studies, and it's also been observed in adults. So that is a concern in the field that we're constantly monitoring. Asthma, diabetes, changes in the liver enzymes, high blood pressure, questions around infertility, breast cancer, infant birth weight, and then child growth, learning, and behavior. Now, the studies have observed these, but they haven't been observed consistently for a long enough period of time for us to be able to definitively say there's a causal relationship. There is a pattern. There is a biological mechanism, meaning that the way that these chemicals behave in the body, it suggests that it could have an impact on many of these outcomes. And many of them are consistently showing this in the literature, but we're not yet at a point where we can say there's definitively a causal relationship. For this reason, the National Academy of Sciences and Engineering launched a review of the literature to provide clinical guidance for the committee. I was a member of this committee. In addition, there was a companion committee launched that with this review process that composed of community members. And there was a community member from Hoosick Falls on that committee, as well as other community members from across the country. And the committee was asked to review the literature, provide recommendations for clinical guidance that could be released to clinicians, as well as provide some feedback on testing for PFAS. I've also provided for you here links to the published epidemiology literature that we maintain on our study website here at the University at Albany. And then there's also a toxicology database that is maintained by researchers out of Texas. It's an excellent resource to keep up to date on the toxicology and the environmental impacts of these exposures. In summary of the literature review conducted by the National Academy Committee, They identified sufficient evidence of an association of PFAS with certain outcomes. The decreased antibody response that I mentioned in adults and children, dyslipidemia or high cholesterol in adults and children, decreased infant and fetal growth, most notably birth weight, and then increased risk of kidney cancer in adults. There was limited suggestive evidence, and what this means is, in the National Academy lingo, is that there are a number of studies suggesting an association between these exposures and the health outcome that's listed, but not enough and not consistent enough, or there might be challenges with the study design, meaning it's a very small study, or maybe they didn't measure the outcome using diagnostic information, or had a limited measurement of the PFAS. So there was some challenge with the bias that might be resulting in that study. So not enough to say there's sufficient evidence, but there's also not enough to say there's no association. So it's in the middle. And again, with all of these health outcomes, things that are consistently being observed in the literature as being a concern that we need to keep studying and trying to understand the potential risk with PFAS. The clinical guidance that was established or recommended from the National Academy report used the information we had at hand. The challenge we have is that with any chemical and health outcome association in epidemiology, we always need lots and lots of studies over many years for us to be able to say definitively that something's causal. And this is because we're studying people. So unlike studies in animals, we don't have the capacity to control everything around the study participants that are in our studies. So everyone has a different type of diet, everyone has a different occupation, everyone has a different family history, and we do our very best in each individual study to account for all of that variation so that we can best understand the association between the exposure and the health outcome of interest. But the other thing we also must do to understand the issue is to repeat those studies as often as we can to see if we keep seeing that consistent relationship. And so it takes time and it's very slow. Given that, the committee spent a lot of time discussing how do we put forth these recommendations for doctors when there's still a fair amount of uncertainty in the literature, and yet we have also a fair amount of information telling us that there are things here that we can't ignore, that it's really looking like there might be an issue that we have to pay attention to. And with that in hand, and there's lots of information in the report, and I have a link to the report, the committee suggested that for those with less than 2 nanograms per milliliter concentration of PFAS in their blood, and we went with the combined mixture, not just one PFAS, but the combined measurement in the blood over time, that they can, those folks who have that measurement have the regular standard of care. But for people above 2, the standard of care, meaning we always want to measure, in older adults in particular, cholesterol levels. We always want to make sure people are going in for screening for breast cancer. We want to make sure people are being screened for blood pressure. But if people have above a 2, we want to make sure the clinicians know that they have to pay special attention and really do our very best to make sure those folks are getting monitored as they should be in their regular standard of care, and maybe start a little bit earlier. And that's based on the concentration. And so again, for those between 2 and 20, which is a large proportion of the population, to ensure that we have that cholesterol monitoring, that we are screening for hypertensive or high blood pressure during pregnancy, and then screening for breast cancer as recommended given someone's age, and to really pay attention to the people who do have that measurable exposure. And then those greater than 20 nanograms per milliliter, again, what was recommended earlier with regards to cholesterol and high blood pressure and breast cancer, but to add to that, to pay particular attention to thyroid function, as well as the potential risk for kidney cancer. Kidney cancer is very difficult because there's not an effective screening tool available for kidney cancer. But if you know someone's highly exposed and they're showing signs or symptoms that you would normally associate with kidney cancer, then it is suggested that again, the clinicians be aware of that and look for that and monitor. And again, monitoring for testicular cancer and ulcerative colitis using those same principles. It's important to note these are recommendations. They have not been formally adopted. ATSDR did take this information to draft clinical guidance for clinicians, particularly those working in communities with the potential for high exposure. With regards to a comparison, one of the things the National Academy Committee did is we went and looked at other reviews that had been conducted before. ATSDR, the Agency for Toxic Substances and Disease Registry, had completed a review of the literature about a year before the committee with the National Academy began its work. And we took that information and also reviewed it. And the reports are very similar, particularly with regards to cholesterol, birth weight, the antibody response in kidney and testicular cancer. There were slight differences in the other outcomes that were listed, and there's a table here to show that. And with thyroid disease, breast cancer, and ulcerative colitis that are listed on the right, the ATSDR reviewed concluded that there was no consistent evidence, whereas the National Academy report reported it as limited or suggested. Part of this is time. So remember, the ATSDR report was completed earlier. Additional studies came out and were published between the ATSDR report and the NASEM work. And whenever that happens, again, we have that changing narrative as we, again, learn more with regards to these chemicals. And again, I've provided websites here for you. My area of research historically has been focused very much on children and infants, and this is a special interest of mine. It's also obviously a very common question I get from families. There are still a number of evidence gaps in the literature related to reproductive outcomes and children's health. The literature around developmental outcomes, so ADHD or delayed development or delayed progression to key milestones as infants learn to walk or to move or to have social interaction, is very mixed, meaning some studies are showing an association with the PFAS and some don't. And again, because these are endocrine disrupting chemicals, these are outcomes we're very focused on because we know those are hormonal relationship in the development of a child. And so again, this is just an area we're paying continued attention to. We don't have enough information yet to understand what the potential impact might be on children. Cancers other than kidney, breast, and testicular have not been studied as well. And again, there's a call for additional research, particularly in the area of liver cancer and other cancers of interest. And similarly with the male and female reproductive outcomes, other than hypertensive disorders of pregnancy. And again, because these are endocrine disruptors, these are typical outcomes we want to pay attention to. Similarly with the endocrine disorders, gestational diabetes. And then really, a very significant challenge right now is the issue around breastfeeding. And I think I have a slide here. Yeah. So the challenge we have is we know that infants can be exposed to PFAS through breastfeeding. And it's clearly an area of great concern to families who are trying to decide whether or not to breastfeed their children. There are a couple of things that we do know. We do know that breastfeeding is excellent. It's very good for the development of a child. It also has positive health effects for the mother that's breastfeeding. Overall, the literature is extremely consistent on that front, and it's usually something that is recommended for a family to do. The challenge is if you choose not to breastfeed or are not able to breastfeed, and that happens a fair amount for a number of reasons. Formula, especially if you're mixing it with contaminated drinking water, could still contain PFAS. There's also a number of studies showing that the powdered formula itself could contain PFAS. And then, of course, you also have to worry about other contaminations of water like lead. And this is an issue that we saw in Flint, Michigan, and in other communities that still have lead in their pipes. So again, the recommendations with regards to whether or not women who have been exposed to PFAS should breastfeed are very challenged. Right now, the assumption is for the vast majority of women, the recommendation would be to breastfeed because the benefits of breastfeeding could outweigh the PFAS exposure. However, because we don't know if there is a threshold, meaning is there a level of exposure to PFAS through the breast milk where it's too high and we would recommend not breastfeeding, we don't have that number and we don't know what that is. So that's challenge number one. The other challenge we have scientifically is that if we know a mother has a certain concentration of PFAS in her body, we don't yet have enough understanding of how that translates into how much PFAS will be in the breast milk. We know there'll be some, but we don't know how much. And then if there's PFAS in the breast milk, we don't know how much will go from the breast milk to the infant. We know there'll be some, but we don't know how much. So those two areas of research are critical for then taking that information to establishing really effective policy and guidance so that families can make informed decisions. For that reason, the NASEM report really advocated for increased funding and strong advocacy for commencing with this type of research very quickly. It is something that we need very as quickly as possible to have that important information for families. In terms of what has happened in the literature since this report was released, and it's important to note that one of the recommendations of the National Academy report is that the epidemiology literature be reviewed and evaluated and discussed in the scientific community at least every 5 years or more frequently if a lot of research is coming out, so that again the clinical guidance as well as other recommendations can be updated as needed and on a regular basis. In general, most of the findings epidemiologically are very consistent. So there's again continued support in the literature for the association of these chemicals with lipids and cholesterol. Continued support of the impacts on the immune system in adults and children. Similarly with low birth weight, although again, the associations with low birth weight, there is a consistent association there, but not necessarily at a level that would be detrimental to the child. There is it's a several ounces effect is what we're seeing. So it's consistent and it does reduce the weight of the infant, but not to a point that clinically it causes great concern. But because it does have that consistent finding in the literature, it tells us that there is the potential to have other outcomes that we need to be focused on. And again, the association with blood pressure. I've already discussed the issues of breastfeeding. And again, the literature is really starting to also try to get a handle on the less persistent PFAS. So the challenge with these, as I mentioned, there's still an assumption, given that they're similar chemically structured, that they could still have health effects similar to what we're seeing with a more persistent PFAS. And in fact, some of the work out of North Carolina is suggesting that. But they're harder to measure. Typically, when we have a chemical that's less persistent, we can't measure it in the blood as well. We usually have to measure it in the urine because it is excreted so quickly. And so that makes it more difficult to understand. It's good that it's less persistent. That is a good thing, but it doesn't necessarily mean it won't have any adverse health effects. And so that's the challenge we have now and where some of the new studies are starting to focus their energy. And then mixtures. Historically, in environmental epidemiology, we've studied one chemical at a time, but that's not reality. As I already mentioned, these PFAS occur in mixtures, so we really need to understand them as a mixture. We also need to understand how they might have an impact if people that are exposed to these PFAS mixtures are exposed to other things like metals or exposed to other exposures related to the social environment or other or poor air quality and so on and so forth. So we really need to understand the totality of these exposures. There's another tool that has been created by EPA that is also updating the epidemiology literature for everyone to keep track of. And again, I've put the link here, and it's a very nice dashboard that you can monitor and access the epidemiology evidence on a regular basis. So what do we know? So we know there's widespread contamination of the drinking water systems. We know that certain occupations, especially firefighters, military personnel working with firefighting foam and manufacturer facility workers, are at great risk of very high exposures. We know that these environmental and occupational exposures can lead to measurable concentrations in all people. We all have measurement in our blood, but it varies greatly. And while they're decreasing over time, other PFAS are the other oldest ones are being phased out. Newer ones are taking their place. And again, we do know that the environmental concentrations, what we measure in the water, there is a correlation with what we then measure in the blood of people who have been exposed. And again, there's this additional focus now on understanding the level of exposure to communities from biosolids, as well as through other exposure pathways given our personal products and food that we eat. There's a lot we don't know. We're not going to catch up with that old model of one chemical at a time. There are 12,000. So we need to have a better approach to how we understand the health effects of PFAS. There's much discussion in the scientific community that we should look at these as a family rather than just one at a time, or by a set group of mixtures that typically occur in common with one another. And so this is an ongoing discussion that we're having within the scientific community. And again, less persistence is a good thing environmentally. It's a good thing for people, but it doesn't guarantee that the chemical is still safe. And so that is something that we have to continue to examine and try to understand. And again, there's a great deal that we don't yet know in terms of data for clear clinical and regulatory guidance. This is an ongoing challenge that we're going to have to keep pushing for in terms of our information. There are a number of studies and information that this is not an exposure that's limited to the United States. This is a global challenge. Many countries don't have the capacity to measure environmental chemicals in their water. Particularly those that are lower wealth countries, and yet there is substantial evidence that there can be quite a bit of exposure to those communities. And so this is, again, another area of concern. A number of studies have shown that children who are in immigrant families in the United States who are coming from other countries where they don't have the infrastructure for testing do have higher exposures of a number of environmental exposures, particularly metals like lead and these PFAS. And the clinical community needs to be aware of that as we work with them to understand what these exposures may be doing. Just briefly, I wanted to let you know about the study that's ongoing. So the multi-site health study is a national study. There are 8 sites across the United States. In New York, we have 2 sites in Hoosick Falls and Newburgh. We launched this study just as the pandemic hit, and so there were a number of delays early on, but we worked in partnership with our community members in both communities, and here are just some pictures. We invited community members to participate in this study, and they were each given the clinical results of what we measured in their blood. And we are now at a point where we have just completed the analytic data set, so we can do the statistical analyses of a number of health outcomes that we measured through a series of questionnaires, as well as through blood and urine measurements in the study participants with us. And we actually had a meeting at CDC last week to plan for these statistical analysis, and those are finally commencing. And this is one of the challenges with epidemiology, is that it moves very slowly. But we're hoping to, now that we have our data set, to really start giving feedback to the community as we learn these statistical results. And these are just some of the numbers from the New York site. We have overall, with the 8 sites combined nationally, we have over 3,000 participants in this study as we look to scientific and statistical results to understand these various chemicals. And just as a comparison, I had mentioned the categories from the NASEM report of less than 2, 2 to 20, and greater than 2, and where our study participants are compared to the population in NHANES. And as anticipated, we have, with our 2 sites combined, many more people, almost half are in that highest PFAS group, compared to only 14% of the national sample. And we anticipated that because these are 2 highly contaminated communities over time, and which is exactly why we wanted to have their participation in this study. This study is also funding a number of other evaluations. One is to examine the fate and transport of these chemicals in the drinking water and the historical exposure patterns in for the drinking water environmentally. And so that work is ongoing right now. In addition, we also asked the participants who enrolled in this new study if they had previously participated in the biomonitoring that was conducted by the New York State Department of Health. We asked for their consent to access those data so that we can then look at changes over time in both their health markers, but also in their PFAS levels. And so that now that we have that consent, we're in the process of pulling those samples. We have to thaw them and aliquot them and get them analyzed. And so that effort is ongoing right now. And then I mentioned the newborn dry blood spots that with a method that was developed here in New York. We also asked the mothers of infants who lived in Hoosick Falls in the city of Newburgh over the last 20 years and gave birth for permission to access the stored blood spots to measure for these PFAS exposures, again, to help us understand what we see in children, particularly those infants who were born to mothers who were living in communities that did have this contaminated drinking water, so we can better understand the exposure patterns, but also understand the half-life for women, because the half-life in women is different than it is for men because of biology reasons, not only because of their reproductive history, if they've given birth or if they've breastfed, but also because of menstruation. And so this will help us understand what the half-life patterns are for women of reproductive age. And again, I've provided additional resources here for all of you that I mentioned throughout the talk. And just to thank a number of my colleagues, as well as the community members in Hoosick Falls in Newburgh, who have worked very hard. They've been incredible advocates and advisors, not only on our study, but on this issue in both of their communities. And we're working very closely with them. And then also our grant funding mechanisms for the studies that we have done here in New York. And with that, I'll stop sharing so I can answer questions.
Great. Thank you so much, Dr. Bell, for your presentation and really pulling all of these very disparate studies and pieces of information together into such a coherent, package for us to learn and share with our communities. While we're waiting for some questions to come again, reminder to use the Q&A box. I'll just mention that we will be continuing to talk about PFAS chemicals through the annual Watershed Conference, in particular with a breakout session in the afternoon of the in-person session on October 22nd, featuring presentations from Jennifer Rollison, who's on the call this morning from Newburgh Clean Water Project, who's been an incredible advocate both locally and nationally. So let's see what we've got. Okay, so question, how would you advise communities where water testing is showing some presence of PFAS, though below the EPA standard? Citizens feel that the lack of scientific certainty leaves them vulnerable to possible detrimental outcomes, and that is scary.
Yeah, I can understand. And that's always the challenge. It's trying to make sure communities have the information they need, but then the continued uncertainty is a little challenging. A couple of things. The EPA, when it sets these regulatory levels, does so with a measure of taking that uncertainty into account. And so they have the scientific information they have where they think that the safe level is, but then they add factors to that to add a cushion. so to speak. So if it's below the 4 parts per trillion, even though our goal is 0, that's a good thing. It's a good sign. However, what I would advocate is to be informed and to do your very best to keep your exposures as low as possible. So a couple of things you can do. There are filters filters are effective, but you want to use the right kind of filter. I always have mixed feelings of recommending filters, not because they don't work, but because there can be a financial disparity. So families that can't afford filters, that obviously puts them at a disadvantage. So for at the community, I try to advocate for programs or policies that if you can either put a filter on at the larger water source level, that would be great, or mechanisms in hand to provide filters for in the community for members who can't afford them on their own. And the type of filter matters. The type of filters that work for the older PFAS, the PFOAs and PFOSs, there are different ones for those versus the newer ones that are less persistent. But there is information, your water agency for your community will know that information. And we can also provide it if people want to reach out, we can have links for you. So that's one thing. And then the other is to be aware of what's in your packaging. The community can be aware of if there are firefighting training facilities in your community. Have a discussion with the firefighter companies, make sure that they're monitoring the use of that firefighting foam and how it's being discarded, and if there's any runoff, and make sure and work in partnership with them. Be aware of what's in your products that you're using, and try to minimize or reduce your own exposures over time. And in that way, you can gain some control over what you are consuming, and monitoring that, and then keep monitoring these websites that we've provided and that are available, that will let you know on what the latest information is for that.
Great, thank you. We've got another question asking about access to the slides. And yes, we are recording this session. We'll be sharing that link with everyone who registered for today's program. And Dr. Bell will also be providing a PDF, so you have access to all of those links that she shared for additional information. Are there any other questions from you all? Here they come. Great. Is there a movement to have doctors regularly screening for PFAS?
So this is of great debate. One of the questions that the National Academy Committee was asked is whether about access to testing for PFAS. And this is something that we consistently hear from community members. They want access for testing. The committee spent a lot of time around this issue. We actually consulted a lot with ethicists, bioethicists, and we had an expert on philosophy and bioethics on our committee, because there are a lot of questions that come with testing. Where the committee landed is that if someone wants to be tested for PFAS, they should not be turned down. They should have access to testing if they so want it, that ethically that is the right thing to do. However, there are a lot of challenges with testing. And so the recommendation to clinicians was it should be available, but make sure there's consultation with the patient and with the community members, so they understand the pros and the cons. So some of those, just in summary, obviously the pro would be you would know what the concentration is in your blood at that time, but you don't necessarily know historically what's going on. So we don't know that initial dose that you might have had, or if it's gone down over time. So there's that piece of information. We also, testing itself can be quite expensive. And so for many people, unless they're living in a community where there's high contamination, or if they're an occupational worker, they're not likely to have a very high concentration of PFAS. And so they might be better off, just as I just explained earlier, to focus on trying to reduce any additional exposure to PFAS, because we do know that it'll be excreted over time. So there's that piece. The other challenge is that with the newer PFAS, again, they're harder to detect in blood. And so a blood test might be harder. A urine test could be possible, but the scientific technology isn't there. So all of that counseling would need to go hand in hand before a decision is made of whether or not to test. But the committee ultimately landed on that ethically, you can't deny someone an opportunity to test. The other challenge is who pays for it, and there is no discussion, and I know we caused a lot of angst in the ATSDR and the at the federal level, because there is no mechanism for payment right now for testing. The health department in New York does provide testing for Hoosick Falls and Newburgh and for communities that have very high exposures, but it's not uniform because there is no payment mechanism at this time. And again, the benefit of the testing varies for people across the board, depending on their history. And so it's a little complicated, but there was an ethical that if someone really wants it, they should be given the opportunity. But again, they also should be aware of all the pros and cons of it.
Great, thank you so much. The question about replacement of lead pipes with PVC, is that a concern for PFAS exposure?
That's a great question. The lead pipe should absolutely be replaced. PVC is the standard. I don't know of any concern related to PFAS and PVC. I can double check, but my understanding and it absolutely should happen. The danger from lead is great. It's well established. We need to have those pipes replaced. I don't know of anything, but I can double check and all that, but I certainly haven't heard anything.
Great, thank you. Unfortunately, we've reached our time, and so there's a couple other really great questions here about drinking water treatment to remove PFAS and takeout food packaging and raising awareness for the public. I think some of our conference speakers might be well positioned to answer some of those questions as well. So we hope you'll join us next week, next Wednesday, for our webinar session, and then on October 22nd in Hyde Park for the in-person conference session. We'll be sending out the recording, the slides, and please share this with folks in your networks, communities that you think would benefit from learning more about PFAS. I learned a lot today. Thank you so much, Dr. Bell. I hope you all learned a lot as well, and we'll see you soon. Have a good day, everyone.
Thank you.